I do think that the bispecific T-cell engagers brought on kind of a new dimension to ASH 2020. We now have data from more than 6 different bispecific T-cell engagers that are showing great promise. The key features to the bispecific T-cell engagers is one arm of the antibody, and these are all monoclonal antibodies. One arm of the antibody binds to the surface of the myeloma cell and anchors the antibody to the myeloma cell. And the other arm is looking around to a T-cell in the location. And that other arm binds to CD3 on the T-cell and activates the T-cell. And so you have T-cell activation in close proximity to that cancer cell, to that malignant myeloma cell. And that looks to cause a very significant immune activation in the area and a potent anti-myeloma effect. Now, the nice thing about these T-cell engagers is a couple-fold. First is there was 5 or 6 that bound to the same surface marker, BCMA. BCMA is a great marker because there's not a lot of off-target effects. There's not a lot of other cells that have BCMA on the surface. So it's really merely going after myeloma cells. And the other arm that binds to the T cells, some of them bind to the T cells very strong and activate it quite well. And some bind less strong and don't activate the T cell as much. And so there might be differences in side effects as well as differences in efficacy. And that's what we're going to watch over the next few years. But the other nice thing about these T-cell engagers is there were 2 presented at ASH that bound to different cell surface markers on the plasma cell. One to a marker that's called GPRC5D. And that one actually is mostly limited to plasma cells. It does also have some expression in some of the patients had a little bit of a rash. But when those drugs were given, first IV and then by subcutaneous injection, that more than 50% of patients at what they consider the best dose had demonstrated anti-myeloma effects. That's really amazing. Most of the side effects were in the first 2 or 3 infusions, and then after that, the side effects actually became much lower. And these are therapeutics that can be given over time and over a long period of time, and likely over time at a less frequent dosing. So you can start off potentially with weekly dosing, and we hope over time it can be every other week and then maybe every month. And we'll just have to see what the ideal dosing sequence will be over time. And the last one was the FcRH5 protein on the cell surface that's on a lot of lymphocytes. And that cell surface marker is also on the majority of malignant plasma cells. And the co-binder is also to CD3 to activate the T cells. So FcRH5 is really another amazing target for patients that have multiple myeloma. And what I think we're going to be able to do is bounce back between, target BCMA a little bit. If there's resistance because of no BCMA expression, then we can go to these different markers, GPRC5D. And so it'll be really neat to watch this over time.